So I'm going to talk about the AN-ACC and whether the way we've been working with community transport might provide a way forward for the rest of community support and care services. And Tara, of course, comes from community transport, so she'll be able to give feedback about that process with us, but also about what that means for community transport. Before I do, I just want to step back a little bit and go back to the Royal Commission recommended a new program called Support at Home, but didn't really spell out the details. The government then announced, or the department then announced, a new program, which is and said the outline of how that was being developed. A lot of people were very concerned about that and set up a Support at Home alliance, and we were asked to participate because I have a very strong background in funding system design and, in fact, design the AN-ACC. Where we're up to now, of course, with the change of government, is that the current government's been able to step back from that, and I'm sure everybody knows that the previous government had announced that Support at Home would take effect from next year. That's now been put back a year, so that gives a bit of breathing space. I think there's now 3 options for the future funding of community support and care services in general. And I do know that a couple of people have seen block funding as, everything's still on the table, so don't take block funding off. You could probably have that. So I do think we need a conversation in the sector about what's going to work well, what's going to be best in the short term and the long run. And I suspect that the answers, what's best in the short run and the long run, are different. But essentially, I think there's 3 options still. With the change of government, block funding for CHSP does seem to be a possibility going forward. But understand that means that there's still going to be a home care packages program. And so we will end up with a division continuing. And you'll see my second block point about that is that block funding inevitably results in what I call set and forget, where basically you got what you got last year with perhaps a little bit of indexation. But I think the evidence is in looking at the budget investments in CHSP versus HCP over the last 10 years. And I've looked at this issue in health, aged care, disability around the world. If you get block funding, it's really good because it's nice and administratively easy, but it's also you don't grow in anywhere near the same way. And I do think so that's one of the options. The second, of course, is that people do decide that the Support at Home program that's currently proposed, or as the government might modify, might actually work. And essentially that's a fee-for-service type arrangement. Just think about going to the doctor and there's a fee-for-service called the bit like that, cap prices, cap volumes and payment in arrears. That's what's been delayed. And the third option, which is the one I'm going to talk about today, which was that we were approached and asked a very obvious question: would the AN-ACC model that we developed for residential aged care actually cover the whole spectrum of aged care? So the project was initiated by community transport, and Tara is here and she can talk about why she did that. But they did that to actually be the test case to say, does the model that we developed for residential care, which is both a classification of consumers and also a funding model, work? And we agreed that we would develop a separate branch for community transport as a direct alternative to Support at Home, so people could actually see what that looked like. We have completed that project, and that's what I'm going to talk about. It was New South Wales only, but very much with the intention it could go national, and it was community transport only, but knowing that we were part of a broader Support at Home alliance, and so potentially it's the prototype for other services, and so that's really the purpose of today. The project went through quite quickly over a couple of months, and the first was really just testing the ideas. Does the model make sense when applied to community transport? We then got through that stage, and Cara then assembled a community transport expert panel, and we actually said, what is it about, what drives costs in community transport? And we developed some classes we could test and refine in a costing study. The major piece of work was then the costing study. And then after we'd finalised it, had a final draft, we took it back to the sector for their review and final decision. So it was very much a co-design project working with community transport organisations. I do want to make a point. This is a new way of thinking and also a new language. So I'll introduce some jargon words. And the point I want to make it is that it's conceptually much more sophisticated than what you do now. But administratively, I think it turns out to be easier. But we've got to just get that on the table. It's not a new block grant funding model, and it's not fee for service with payment in arrears. It is an annual price and volume contract that's got 2 components. One is paying you for what we call capacity. How much does it cost you to have the doors open before you provide a service to a single person? So that's the cost of your office and the switchboard and the admin and all that sort of stuff, the CEO and all those costs. And then the second is activity, and it's weighted for resource use. It's not just in the case of transport counting trips, which is what have been the big debate in community transport forever, but it was weighted for different types of trips. And then there's a set of operational details to get documented in a set of business rules that sit behind it. So before I show you the model, I just want to introduce you to Jargon. I will always talk about RVUs, or relative value units. So it's just a shorthand measure of relative cost. And we said, well, our reference point for this is going to be a standard trip of 15 minutes or less, and all of our other costs are going to be expressed as multipliers of that, and I'll show you that. And the reason we work in RVUs is because dollars go out of date each year, but the RVUs don't. And so the Independent Hospital and Health and Aged Care Pricing Authority will be declaring the dollar value of an RVU of 1 each year, as they do with the hospitals. And so the RVUs stay for years and years, and the dollars just get updated. So the AN-ACC model for community transport is complete. That's version 1 is. It's got three elements, and I'm going to show you each. The first is 5 base care tariffs, which is for your capacity cost of simply having the door open. The second is 8 transport classes, and the last is 4 consumer classes or client classes. This is what a price and volume contract looks like. It says the cost of opening the door is your base care tariff. That more or less looks like a block grant paid up front to give you some surety in your budget for what you're looking like over the course of the year. But there's an activity component which is expressed in relative value units. And in this example, here's an organisation that's getting a base care tariff of $1.5 million. And the contract will be or the funding agreement will be for 50,000 activity units at $10 a unit, plus or minus 10%. So we always put one of these tolerance bands around it that says, if you deliver between 45 and 55,000 units of activity in the course of the year, you've met your funding agreement. And then you've got some rules about what happens if you do less than 45 or what happens if you do more than 55. But essentially, you've got those two components, and any adjustments for activity is only to the RVUs, not to the base care tariff, because that covers you for the whole, having the door open for the whole year. So that's what a model looks like. This is what it looked like for community transport. When we did residential aged care, about 50% of the costs of a residential aged care facility are fixed in the base care tariff. Every home in the country has already got its staff organised tonight, and 50% of their costs are independent of the needs of the individual residents. When we've looked at community transport, 70% of costs relate to capacity and 30% to activity. And we would expect that that percentage would vary, that it'll be a different percent for Meals on Wheels or Neighbourhood Aid or whatever. Some might be up into the 100, but the concept is that we would have a base care tariff across all care settings of care, even though the percentage would vary. In the transport case, that varied between 65% of costs in urban areas in the cities is capacity, but 85% of costs in rural capacity. And so the other sort of headline, I guess, is that we did actually manage to find a classification. Technically, it actually works better than the hospital inpatient classification used in hospitals. So it's actually a very good technical result. And I'll show you what it looks like. So location, we've broken the state, New South Wales, and indeed the country, up into 2 geographic areas. And there's a set of base care tariffs, one set for MMMs 1 to 3, so that's metro through to large rural towns, and another one for the modified Monash levels 4 through 7. And we did a bit of work about what happens when a lot of services have got catchments that cross both, but that's okay, but fairly easy to resolve actually. We've got 8 activity classes, and I'm just going to take you through them just to give you an example. So the first one is an individual person getting a trip less than a quarter of an hour. So that would typically be picking somebody up and dropping them to the doctor. And you'll see the next column is the number. We have 42,000 trips to analyse, and 15,000 of them were that very short little trip. On average, they were 10 minutes. So that's duration mean, and 4 kilometres only. And on average, they cost $9. And you'll see we've given them an RVU of 1. And if you look at the next one, 15 to 30 minute trip, there were 10,400 of them, 22 minutes on average, 12 kilometres on average, $20, and they've got an RVU of 2.24. And if you look down that big list, you'll see that the most expensive item has got an RVU of 26.3. In other words, it's 26 times more costly to deliver one of those than an individual of less than a quarter of an hour. And that one that's called 26.3 RVUs is for an individual needing more than 3 hours of transport services. So there's our individual 8 activity classes. And for the purposes of a data collection and a funding agreement with the department, you would actually, however many you have, you'd end up each service with a small number of activity classes like this, and you just tick a box each time you do one of these. And as soon as you do one of an individual less than a quarter of an hour, you're raking up 1 RVU. So that's the data collection and reporting system, is that the activity classes. The last comments down the bottom are just about the technical performance. It does perform really well. The classes are all very homogenous, which is what you want, and a lot of the variability in cost between services is explained, which is also what you want. Here's our 5 base care tariffs, 3 for metro and 2 for regional. And you'll see the relativities between them as well. The RVUs for them are different, and you'll see the BCT there. The average here, the one we've calibrated it, everything else has been pegged towards a metropolitan service who does between 50,000 and 125,000 RVUs. So you'll see now that we're defining services, those small, medium or large, based on their total RVUs, and you can get to 50,000 units of activity by doing a lot of little tiny trips or not so many big trips, which is exactly what you want, because you want to be able to cater for metro as well as rural. And then we've got 4 client classes. So a person gets assessed as needing transport in this case, and would be classified to one of 4 classes: casual, low, medium or high. And a transport service would get a referral for somebody who's a casual user, and they get 47 RVUs to put into their activity pool, and the person who's high would get 1,146. And you'll see that the way that works is that you can get to 50,000 by having lots of little casual users or fewer high needs people. So there's quite a bit of work yet to do to work out the assessment system to actually get everybody into their right classes, but there's only 4 classes for community transport. So the outcome I've got is something that we think is pretty credible. Statistically, it's very robust. If we did this work in other sectors, in other parts of community aged care, we would expect a typical similar result. 4 classes for consumers, 6, 8, maybe 10 activity classes, maybe only 1 or 2, depending on the nature of the service. And then for a consumer who's got multiple care needs, you'd obviously use some combinations. We would argue that one of the most important things to try and achieve in reform going forward is to have one model that goes right across aged care from residential to community aged care, because the Independent Hospital Pricing Authority will be pricing 1 RVU every year, and it will apply across all care settings, which actually allows for a level of growth in programs like CHSP that it hasn't had before. That said, it is new, it is a different language. It looks at first glance to be much more complicated, and there are many people in the sector who would feel more comfortable with block funding and would be very happy if they can see it retained, at least for now. So I think the next issues really going forward is that I think community aged care providers need to have an opportunity to debate the sort of funding model you want, and particularly the idea that retaining block funding might be back on the table, at least in the short term. But if not block funding, what's a shared view about a better alternative that can be put to government? And the way to do that is via the Supported Home Alliance. I don't think anyone should assume at this stage that the Supported at Home program guidelines, etc., that the department was issuing will go ahead. My understanding is that the Minister is very committed to really taking that off the table and genuine consultation about a different sort of model. That's all I wanted to say.